Welcome to the Possibility Action Network podcast. I'm your host, Stephen Middleton, aka Possibility Man. We're committed to bringing you guests who strive to better people's lives and serve as a force for good in the world. Our guest today is Dr. Irkita DeRowan. She is a triple board certified medical doctor. She is also well known as a thought leader and innovator in healthcare. Her skill set includes merging medicine with technology. She has a passion for health equity and offering medical services to underserved populations. She hosts a podcast show and she is a mentor to medical students. Dr. DeRowan, you are a busy professional. Welcome to the show today.
Thank you so much for having me. You sent a warm welcome. So hopefully we'll have a great discussion where we can chat about a lot of things.
Look, I'm looking forward to it. I've been looking forward to it for a while. And just one program note before we get started. To our viewers and to our listeners, your support matters and is appreciated. Follow, like, and share us wherever you find this podcast. Our sponsor information is below the description. Thank you for being with us today, Dr. DeRowan. Look, this is the Possibility Action Network podcast, and we're all about possibility. So I'm curious to know, at what point in your educational career did you decide to become a medical doctor?
Oh, that's a good question because it's so different for everyone. I would say I decided quite early when I was probably, and there are pictures of me when I was like 3 years old and Christmas with the little doctor set, but I think that it evolved over time because a lot of kids, they'll say, oh, I want to be this, oh, I want to be that. I think at one time I wanted to be an archaeologist or a weather girl as well, but I kind of stuck. I think with all of those and the things that those have in common is that they involve science. So I always had a curiosity within me and I loved people. I'm very chatty, as you guys will probably see or hear as you listen to this podcast. So I wanted to find something that merged my love of science and curiosity with people. And that seemed to be healthcare. And throughout time, I ended up helping sick family members. Like one of my grandmothers who used to watch me after school, she had diabetes. So I was the only one brave enough to help her with her injections. And I was like 8. So it just evolved over time and I stuck with it.
Wow. So did you know before you graduated high school, or was it just like a curiosity before you graduated high school?
I think I knew because I had done a lot of programs. Even in high school, I was a part of the shock trauma mentorship group where they took students to environments where there were shock trauma hospitals, and we would shadow on like Fridays, like twice a month and things like that. And then I was very methodical when I was choosing my undergraduate program. I really wanted to go to an HBCU, and I knew I wanted to study pre-med and medicine. So I looked specifically and kind of ranked where I wanted to go according to the number of Black students that were able to matriculate into medical school after leaving. So I kind of ranked my programs, and I fell in love with Hampton University. Shout out HU, go Pirates. And I decided to go there, where I actually did an early medical school selection program where the summer after my sophomore year of college and the summer after my junior year of college, a group of students from 15 different HBCUs and historically Latin schools came together, and we kind of lived together in a house and did like pre-med courses. It was like real world, but for like nerds. And we lived in the same brownstone. We studied together. And if you did well, we continued on to spend our entire senior year at Boston University. Wow. And then I ended up going into medical school there. So it's kind of a little putting your toe in the waters to see if it was good for you. So I stuck with it.
Wow, that's fantastic. And, it does seem like you did know early, but I want to ask you one other question along those lines. So when did you really know that you had the right stuff? Because it's one thing to have the curiosity, I want to go be a doctor, as a whole other matter, when you're in those courses. So when did you know that? When did you know that?
I think that I've always been bold and I've always had audacious goals. And I've like even in high school, like what people, like besides type A people, kind of go through a list and rank and say like, okay, how many students go and how many people do well. So that was always within me. And I think that I was really confident. And then being in an HBCU environment, it helped kind of foster and grow that curiosity. And I actually I hadn't heard about this particular program that I did until one of the deans came by and they're like, Arkita, a rep is coming from the school, you go to that. So it's just those people who are looking out for you. Yeah. So I think I always kind of had that, like, I think I can do it. But one thing I will say about being a minority or a Black person in medicine, they kind of tear it down for you as you kind of progress. So once I got into the majority school, it was kind of unknown. It kind of took my confidence away, I'll say, and kind of made me have imposter syndrome. Uh-huh. So there were opportunities where a lot of students would go, and then you would be like, am I good enough? Those questions started to come, I think, once I got to medical school. And it was difficult for everyone. But I think that sometimes you may tell yourself stories about you not being able to do it or not being able to accomplish it, or you may come up to barriers where you can't. So that's where it comes into having a great foundation, whether or not that be your faith, your family, your friends, and just having all that come together to kind of support you and get through it, because I don't think it's easy for anybody.
Yeah, I got you, right. And we'll may come back to that topic because I know you've spoken a lot about the imposter syndrome, but we may come back to that. So look, you are among the few doctors I've met, and I've talked to quite a few medical doctors who is triple board certified. I'm just thinking about my doctors now. Some are double board certified, but triple, and family medicine, lifestyle medicine. And there's a new one that I didn't even know about until I met you, diversity medicine. Why these certifications? Why are they important to you?
So, I will say that I guess I need some different hobbies other than medicine, but I think I'm working on those. I initially wanted to go into primary care because, as I mentioned, I've always had the love of facilitating, finding more information and helping people in kind of learning that. And what better method is that to help people from the cradle to the grave than family medicine, because we take care of all ages. We can do different types of environments, so you can kind of transform yourself. I'm a person who's very curious, and I guess maybe by your introduction, people may notice that I like to try a lot of different things. I'm not always in one zone. So I think that it was a good field for me, because if I were to become a neurologist or a dermatologist or something, I think I probably would get bored with doing the same thing every day. So I loved coming in and just hearing people's stories and seeing them progress and trying to help them through the phases of life that come in terms of their health as life progresses. So that's why I picked family medicine. And then as I continued on in medical school, they don't teach you a lot about, I mean, we have like a nutrition module or something, maybe like 2 weeks or something, but a lot of care is reactionary. So they're teaching us how to treat diseases or how they come together and stuff, but not how to prevent them a lot. So I was very curious when I heard about lifestyle medicine, because it talks about the different pillars of health being eating well, more plant-based diets, things I should work on, exercise, sleep, stretching, and all of the things that kind of help promote well-being. So I figured not only with my patients I could apply that, but I could also apply that to myself or my family members to just help us kind of prevent those diseases that everyone is going to come across, and figure out ways to kind of come to that and come with some kind of combatants with it. And then for diversity medicine, it is a newer field. It is under the Academy of Public Health. And I have always been an advocate for promotion of people being themselves and being different. And I think that there's a space for that in healthcare, not only being a healthcare doctor or with the other people who also influence healthcare, like nurses and nurse practitioners, all of those kinds of people, but also we need that diversity in healthcare because the world is diverse and everyone's going to have issues. So I've always loved working in underserved communities. So underserved communities being socioeconomic, being immigrant, being LGBT, and all of those kinds of things. And I'd love to advocate for the rights of those patients. I worked previously in underserved community health clinics. I've given discussions on health equity. I've worked in health equity work groups. So when I heard about the diversity board certification, I figured like, this is like my thing.
Yeah.
So I definitely explored that more, and I decided to pursue a certification in it so that I could be a subject matter expert and help spread that to other organizations as well as other healthcare systems.
Yeah, that's fantastic. I mean, as a woman, you may recognize this question, and also as a African American, you may also think about this. Right? So I want to ask you. Let me ask you before I say anything. How old were you when you met your first doctor, who happened to have been an African American first, and then secondly, who happened to have been a woman?
Okay. So I think that I'm an anomaly because I grew up in Prince George's County, Maryland, where I would say about 90% of people are African American, and well, at least when I was growing up, and we were the most like affluent African American area in America in the US since the 70s. So I had Black doctors growing up. But when I got to medical school and I asked my friends, remember how I told you there was kind of a group of us who were kind of placed together. And of course, we became lifelong friends from all different HBCUs and Latino communities. And you would ask them, I would have friends who had never seen one until we got to medical school. And then going to medical school in Boston, that still was rare to even have one there. So or when your students would come up to you and they'd never seen anyone, or a patient. So it's definitely people who sometimes wait lifetimes, wait until they're in their 20s or their 30s. But I was fortunate enough to have several African American doctors growing up. And even when I went into college, I had an African American female doctor that was home for me.
Yeah, well, you're fortunate. I was born in the early 50s. And I don't think I met my first Black pharmacist when I was 20. My first Black physician, I think I was in my early 30s before I had that experience. Yeah. So, but look, you mentioned lifestyle medicine, and I know in lifestyle medicine, you all are concerned about not just giving pills, but also asking patients about, their nutrition and the like. So tell me, how useful have you found proper nutrition for reversing some chronic conditions?
I think that proper nutrition is the pillar to not only preventing, but even reversing, like you said, some medical conditions. There's kind of like the father, he's not really, of what I would like to think of as lifestyle medicine, Dr. Michael Greger. And he has a book called How Not to Die. And then he had a follow-up book called How Not to Die. And I feel like I'm doing like an infomercial right now. I want to like get it off my bookshelf and show you guys, because it's an amazing book, because they have evidence-based studies, which I love evidence-based medicine, like that shows us like that it's not just like heebie-jeebies and hooky things, but they've shown studies where people who had taken food that has more antioxidants, which can help prevent different things, help decrease inflammation that causes a lot of things, help even turn back heart disease and diabetes and all of those things, where people, when they implement a plant-based diet, they can feel 30 years younger, or they can add years onto their lives. His first story about it was when his grandmother was, I think, in her 50s or 60s, she developed heart failure, and it was really pretty bad. And she incorporated a whole food plant-based diet, and she went on to live another 30 years.
Wow.
And then that was repeated. Like, so she lived into her 90s. So there are so many instances of that, and some studies that back it up, that show that a lot of the things that we're doing to our bodies, eating meat, and which is delicious. We just had Thanksgiving, but I don't know when but all of these things can be done in moderation. But if you utilize these things and you look into what can help you live a better life, you actually can. You can get rid of some of these joint pains that you have. You can improve your vision. You can improve a lot of different things and aches and pains and dysfunction that sometimes the healthcare system tells you that you just have to live with.
Yeah, and that's one of the reasons why I wanted you to be on the podcast, looking at your profile on LinkedIn. And as you well know, the CDC keeps track, of certain chronic conditions. And I'm not sure what it is today, but in the past, I noticed that they said that there are certain populations that have a higher incidence of chronic conditions than the majority of the population. Is that about true now? Because my research might be all outdated, so.
That is true. And there are definitely populations in which they say that we have higher instances of diseases. For instance, African Americans die earlier from all causes of diseases, no matter, and that's like all of them. So there's a problem with that. Why? I like to tell my patients for some things, it's not only genetics, because it may be habits. You may say that diabetes runs in your family, but it may be because nobody runs in your family. So trying to implement some of those things to kind of counter the things that we've had, because we're trained, we eat similar to how our parents ate and their grandparents ate. So sometimes we need to make changes with that. And some things are genetic, like some people process certain things differently. There are a lot of diseases that run in Asian communities or even in Native communities that you may see more in a bubble. But there is no reason that with the types of technology and the advancements that we have in healthcare, that there should be such a large disparity in a lot of diseases.
Mm-hmm. Yeah, so let's look at a few of them. And I want to make sure that we get the word out here. Can you just give us maybe 3 chronic conditions that affect people, worldwide, and we're in the United States, or that affect Americans? And then we'll kind of look at how foods might be able to help that situation.
Sure. So hypertension, also known as high blood pressure, diabetes, there are 2 kinds. So one is type 1, which is genetic. It's an autoimmune disorder that your body kind of affected by. A lot of times you get it in youth. So it's usually juvenile onset diabetes, although that's evolving. And then we have type 2 diabetes, which is the kind that is usually influenced by social habits in terms of diet and exercise. Now, with more children becoming more sedentary, they are getting type 2 diabetes earlier. And then I guess for a third one, we can think about something like high cholesterol, which kind of goes along with the high blood pressure and things like that. But you can kind of get deposits in your arteries. All of us get them as we get older. Even from age 3, some people will have deposits in their arteries. But depending on what they eat and all of those kind of things, and the types of fat that they ingest, they're can put you at higher risk for it to kind of clog your arteries. And that's some of the things that can lead to a higher risk of having heart attacks and strokes.
Yeah. Okay. So I'm going to ask you a couple of specific questions on these conditions as a medical doctor. I know you don't have a patient in front of you, but I want to throw it out there, see what you tell us. So type 2 diabetes, do you believe that a person that has the Possibility Action Network, of reversing type 2 diabetes by just changing, or at least, making changes in their nutrition? Do you think that's possible?
I think it is possible to reverse a lot of the damage in diabetes by changing your nutrition, incorporating exercise. The muscles that are larger in the body sometimes help with the breakdown of sugars. There's a big problem sometimes where if your diabetes progresses a lot, it may cause some of the cells in your pancreas, which it secretes the insulin and the glucose and the things that you want to help fight with the sugar, regulate the sugar. Sometimes over time, if your sugars are too high, your cells start to die and they don't work, and you may need insulin. So I would say that there is a great possibility in reversing a lot of things with diet, especially diabetes, But I would suggest people talk with their doctor and they can incorporate these things, but I wouldn't suggest not taking any medicines
Oh,
because
of course.
medicines can sometimes help with these things depending on what you can. And incorporating some of these healthy lifestyle changes can sometimes help you get off of some of the medicines you are on. So if people are incorporating these things and they're noticing large jumps or decreases in their A1C, which is the average of your blood sugars over 3 months, or your daily glucose, if you continue with that, some people are coming off medicines that they've been on for a decade.
Yeah, and I'm glad you mentioned earlier, though, to consult their family doctor. I'm a big advocate of nutrition, but I'm also a big advocate of people not making these types of changes without their doctor knowing about it. Okay, so number two, and this is going to be a different, challenging one. I live in the South, and I don't know if I've just stereotyped the South or not, but let's say controlling one's weight. Can you do that in your kitchen? What do you think?
Absolutely. So it's like I said, it's kind of this thing about families and what runs in your family. So a lot of my family members are from the South. My mom's side of the family is from North Carolina, and my dad's side of the family is from Louisiana. So people like to eat good. But it's about moderation. It's about what you're ingesting. You can still season some vegetables. You can still have meats if you would like, although studies have shown that a more heavy plant-based diet is more favorable to healthier life and longer life. But if you choose to still eat meats or fish, like you can season them, but you don't have to deep fry them all the time or get an air fryer. There are opportunities to kind of also stay active. So if you have a large meal for the day, it's okay to go for a walk or a run. Everyone is not a runner. Yeah. So it's okay to try to incorporate other things that keep your body moving, doing things with your family, like going for a walk, going to the zoo, going to the mall where it doesn't necessarily seem like you're getting your working out too hard. Yeah. Although we do recommend that you do have moderate exercise where your heart is pumping kind of in a great way, at least 150 minutes a week. So trying to figure out something that you can do. And one way a lot of people get discouraged by working out 150 minutes a week or 30 minutes for 5 days is they don't have enough time. They're at work. They have to put their kids to sleep, those kinds of things. So it's okay to do it in 10-minute increments. So if you want to get on a treadmill in the morning for 10 minutes or 30 minutes while your kids are asleep or at nighttime, and then do another 10 minutes of some stretching or some yoga or some bar method or whatever, some dancing, it's okay to mix it up and it'll add up over time.
Yeah, that's great. So to move on, I know that you work with the Her Health Collective. Could you tell us what that's about?
Sure. So I'm no longer a consultant for them, although they're a very lovely organization, and I may continue working with them in the future. I had a lot of projects going on, so I had to step back. But the Her Health Collective is amazing. They're an organization in which they help kind of advocate for wellness of mothers. So I'm not a mother yet, but I know a lot of mothers, and I know that a lot of my patients who are mothers have a lot of difficulties putting themselves first. So they help bring wellness experts in who can help people talk about weight loss, talk about sleep, talk about the things that they may be dealing with, like postpartum depression, and how to advocate. And it also gives them a sense of community. So they have places where you can go and chat, they have certain meetups, they have a podcast, and all of these things that just brings the sense of not being alone in the terms of like motherhood and womanhood.
Yeah, community is so important. And gosh, let's face it, many women are having children in their 20s at a time that know very little about a lot of things. So having an organization, I can see why that would be useful. But in addition to taking care of the body, in my doing my research on you, I also saw that you have expressed an interest and perhaps even service in areas that involved mental health and emotional wellness. And if that's still something that drives your heart, can you tell us about that? Why
I
is that
think that
important?
Of course, I think mental health is very important. I think one in the workplace, because you have to have a state of kind of like psychological safety. If you're going to work in leadership and have this open area, there are a lot of things going on with people personally that may affect the bottom line of you moving your organization forward. So you have to have a priority for wellness
Mhm.
in terms of that. So I talk a lot about that when I'm consulting with different organizations. In terms of patients and in life, we have a lot, as we've seen with the pandemic, of just sadness going on or anxiety because there's a lot of things that are unknown just in life. And a lot of times people suffer in silence. So it's very important to let people know that they're not alone. There's an uptick in suicidality. I think in healthcare and in dentists and physicians have some of the highest rates of suicide.
Mm.
So figuring out ways to make people not feel alone is important, to know that there are resources out there. There's a great number that just came out. You know how we have 911 for emergencies now, they have changed the number for the suicide safety awareness number to 988 to make it more accessible and to have people to talk to. And then also figuring out ways in which people, like you said, are a part of the community. Some people have lost family members, some people are just not feeling themselves. So have fostering and putting together those communities are important. Also, people who may have suffered, like with the Her Collective, postpartum depression. A lot of women, they feel like they have the baby blues, but sometimes it's a little more than that. So figuring out ways to come together and to talk is important, especially I think in the African American community. It's kind of shunned or not talked about as much. Whereas the people may say, go pray or don't worry about it or you're good. But sometimes people need to speak to therapists. I think that everyone needs a personal therapist, to be honest. But it's not just when people are feeling well. Sometimes you might need to think through your processes or kind of process what you've even been through.
Yeah.
So I love to advocate for people to speak up when they're not feeling well. I love to advocate for communities to be built around wellness and for organizations to prioritize wellness.
Mhm.
So it's something I love to talk about.
Yeah, I got you. So, as you have mentioned, a person who may be suffering or dealing with something that they don't even know why,
Mhm.
that first step, do you think that a family doctor is a good first step for anyone who may be hurting and not know why?
Absolutely. So there's such an intimate relationship between a patient and their doctor. Sometimes it may be more intimate than a partner, or they've seen everything literally. So for this doctor to come and have that private space with them where you can express what you're feeling, you may not even know what's going on. We have certain trainings and tools where we can assess what you're experiencing. You may have noticed when you've gone to the doctor's office, they may give you a questionnaire and they're like, have you been sad in the past 2 weeks? Or have you thought about this? Or have you not wanted to go outside? Like there are tools that can help you, and they can either set you up and sit you in the right direction to say, okay, here's a therapist in your network that you can talk to, or here is someone, a support group we have at the clinic, or even sometimes people need it. Here's some medication that may help you feel more like yourself. Because sometimes there is a chemical imbalance where certain chemicals like serotonin and dopamine and things in the brain can need a little help with regulation, and that's okay. Some people shy away from medications, but sometimes medications are meant to help you. So if you had high blood pressure and you wanted to get better, you take the pill. So sometimes you got to take the other pills too to help you.
Yeah. So how would you, as a doctor, how would you respond to someone who says, I'm embarrassed to seek out a therapist? How would you talk with that person as a doctor, if that person is in your clinic?
I think that I would tell them that number one is very brave that you brought up that you were feeling different to me. That shows that you trust me. I would kind of dive and see, because every person is different, so you can't assume. So
Mhm.
you want to ask them, well, what embarrasses you about seeing a therapist? Can you find another word for embarrassment? Is there a sense of guilt, a sense of shame, a sense of whatever? Then I would ask them, because there are HIPAA rules where the relationship between a patient and their doctor, or the patient and their therapist, is kind of just between you guys. Who's going to know?
Yeah.
Number three, so are you blocking what can help you feel better? And then if they're still not ready, like, it's no rush. So you can send them home with those things to think about and follow up with them maybe in a week or two. If they're in a way where you're concerned, where I'm concerned, I might say, come back in a week or come back in 2 weeks. Or figure out a way to do it in the portal where you check in or you do a phone call and you just work on it. So if they're not ready for that right now, but you're comfortable talking to me, how about we come back in 2 weeks and we see where you're at, or give you some assignments of things to work in. Can you journal if you don't want to talk to someone else? Can you use an app? There is so much technology coming out in the healthcare system, so it may not need to be a video visit or an in-person visit. Like, maybe they'll use one of the new therapy apps where they text them or something like that. Like, what's prohibiting or causing the embarrassment, and how can we overcome that is important.
Right, that's great. You mentioned the pandemic earlier. That made me think. I know that I'm assuming we're at the tail end of COVID-19 now. But my question is, how is the healthcare establishment doing at this stage in the pandemic? How are we doing?
I like that you changed it to stage, because it's not over, but I think that we're at a point where we're figuring out a new normal in how to live with COVID and transition, because people are still passing away from it. So how are we moving forward after these 3 years into this next phase? But I think that the healthcare system is kind of in an interesting place, because, and I'm going to say these are my personal quotes, okay. But I feel as though organizations and the government and all of those kind of entities want us to be over. Well, they want COVID to be over just as much as we do. I want it to be over too. But sometimes we rush and make changes to certain things, like decreasing the mask and stuff like that, which may actually help us. So, for instance, even outside of COVID, RSV is like on the rise, the flu is on the rise. Whereas if they mask the children in the schools, it might have helped us not have this much of an impact. So that's one thing. But I will say, just on the healthcare front, I think that, of course, it's way better than we were in 2020. Like, we don't have Mack trucks full of things that we don't even want to think about anymore. And we are not having our ICUs filled and all of these things, because we have the vaccine. There are mutations and things that are making it more livable with us. So I think that we've grown tremendously. And I think that there's a lot to have been learned from the healthcare system. I think in terms of healthcare technology, it's at an interesting place, because I think especially with telehealth organizations, like, everything blew up probably quicker than we would have imagined to be utilizing telehealth. I'm sure before 2020, a lot of people didn't even know what that was. Yeah. And I had been working in it years before, and people were like, oh, that's not real, don't do that. And now everyone's like, oh my goodness, you're an OG in telehealth. So I think things had dramatically increased, and now we're at that point where people are starting to go in person with their doctors and things, which I think is wonderful. But now they have all this funding and stuff, and it's going down. So figuring out how to have that balance of the in-person health and the technology, the telemedicine organizations that aren't affiliated with any hospital systems, and how you can merge those and how you can communicate, and where do you go for the next step, and the next level will be quite interesting. So I think that we made a lot of progress since we're in this new phase. And I think that it's wonderful. People are starting to be able to get back and get the colonoscopies and the pap smears and all those screening tests that they needed and they've been missing. Like kids were very behind on their vaccinations, not just COVID vaccinations, but kids need their like measles and mumps and all of those things. So we won't have that again. So I think that it's great that we are in this place where we can kind of connect more in person.
Sounds good. Yeah. So, in the US, where you and I both are, we are living, all of us, in the 21st century. But then I've heard people talk about disparity in healthcare. I don't know your views on this, but I'm just want to ask you point blank, are there disparities in healthcare in the 21st century? And how do you explain that?
Absolutely. I think I could talk for hours about this, but I think that there are historical contexts and doctrines in place that make certain things go on for generations. So there are definitely disparities. We can see this, and it's not as explicable. Like when we were talking about how African Americans die early from all causes and all diseases, and how Black women have a 3 or 4 times more likely to die in childbirth than white women. Even rich people, you've seen like Serena Williams, who was not listened to when she was having her daughter, and she has all the money in the world, and she almost died because people weren't listening to her, and she actually had blood clots in her lungs. Yeah. Or when you have all of these things coming together, where a lot of people love to talk about the social determinants of health, but it's a real thing. Like we have food deserts in places where minorities live more than non-minorities. We have interesting education systems where there may be disparities in those things. Certain people are more likely to take certain jobs. We have a lower amount of doctors in more urban spaces as well as in rural places where it's needed. And all of those things come together to make it more difficult to obtain health care. So as we kind of eat at those things, we have to look into the zip codes and see who's living in those zip codes and figure out what can we do to make it better? What can we do to give this woman who may be African American the same outcome as this woman who's the same age, same background, same socioeconomic status, who may be Caucasian. And there shouldn't be a difference, but there is. And now we're even seeing in things where we're doing a lot of changes in terms of like the measurements that they have for kidney numbers and things like that, where they said that because African Americans have more muscle mass, their kidney numbers can be this number as opposed to this one, and they need dialysis later. Who's dying from dialysis? Black people. So all of these things kind of built up, and a lot of it came from like the olden days, like where they had the father of gynecology made all of his experiments by not anesthetizing Black women who were enslaved and just doing practices on them. And they called him the father of gynecology. Or when they learned about how like radiation works and things like that on a Black man who had a car accident, and he went in to have his bones fixed, but they extracted his teeth and did experiments on him for 5 days before fixing that. And then about 5 or 10 years later, he died from the results of that radiation. So there are countless stories over time. I know a lot of people like to pick on the Tuskegee experiments, but there are so many that have kind of shaped the healthcare system. And even our top healthcare organizations, like people love to talk about Hopkins and all of these things, and a lot of their leaders at the time made transformational things like transformational healthcare, but a lot of it was at the risk of Black people. So of course, over time, there has been some mistrust and things like that, but we can't blame it all on mistrust. Sometimes there are reasons beyond that. or even biases within the people who work in the healthcare system, like we were talking about with Serena Williams, where they just weren't listening to her and they felt like she was not in pain when her lungs literally were full of blood.
Mm.
So there are so many things. So that's why I'm such an advocate for the diversity medicine and helping other people understand these disparities, because at this point in time, Black people only make up 5% of physicians in America. So
Mm.
there are 95% who aren't. So studies have actually shown that Black people do better when they're seen by a Black physician. But like you said, you didn't see your first Black physician until you were in your 30s.
Yeah.
So it's not possible for everyone. And it probably shouldn't be. Like, why can't everyone treat patients well? So we need to work to advocate to showcase not only why people may distrust the medical system, but how can we make it better and what are our next steps?
Mm-hmm.
So that's what a passion is of mine, and trying to decrease these disparities, and we're kind of seeing why and things, but okay, it's enough studying as to why. How do we improve it? So in the next 10 years, we'll say, okay, these numbers are about the same or something like that.
Yeah. Well, the Possibility Action Network is all about that. So you and I are going to work together on that problem.
Yeah.
So you mentioned telemedicine a little while ago, and I want to go back to that and ask you, well, first of all, what is telemedicine? And then evaluate it, how is it doing today?
Sure. So telemedicine is kind of a big umbrella, and telehealth is even bigger. That's what a lot of people are using now. But at its very smallest essence is the exchange of patient care utilizing technology. So there can be remote patient monitoring in the ICU. There can be things where they're utilizing things using machinery or phone. But a lot of people love to think of telemedicine as the exchange of care between a physician or a nurse practitioner or a PA or something like that, and a patient utilizing a phone or a computer. So that's what we'll use telemedicine for now. And there are even different modalities with that. So sometimes people will do, I know a lot during the pandemic, people were not maximizing their technology capabilities. So a lot of people use Zoom to talk between their doctors. There are some telehealth companies that only do it on the phone. So you may see now that Medicare has approved for that to count as a telehealth experience when you're speaking with your physician. You might see a charge on your bill when you call the doctor and they call you back. At least for now. I don't know how long it's going to last. And then there are other organizations where they may communicate via text, where you're texting them back and forth. I've worked for a few companies that have done that. So there are different ways, but basically it's talking with your doctor online.
Fantastic. Okay, so Dr. Akita, you also, as busy as you are, I wondered when I saw this, when did she find time to write? You're also an author. Tell us about Medicine Women.
So Medicine Women is an anthology series. It's my first book that I co-authored with some amazing women from all over the globe, ranging from here in America to Australia to even South Africa. So there are a lot of health professionals in the book, and we kind of either drafted letters to our former selves or told about a story where they were involved in healthcare. So in my chapter, I give a letter to Black medical student females. So letter to like younger me. And it talks about like how I kind of overcame, blatantly to say it, like racism in healthcare and medical education to fight the imposter syndrome of being a Black woman in medicine. So when I was in medical school, I went to medical school in Boston, and Boston is in the Northeast, which is not known for being not racist. So I had some experiences ranging from the dean of the medical school at the time, targeting Black people, to the people who I trusted to teach me medicine. One of my attending physicians who approached me one day when I was very eagerly matriculating through their internal medicine field, where I was talking about patients and things. And one day on the rounds, he asked me a question, and I knew the answer. So like all the other students in the group, I answered. And he was very shocked and taken aback. And he said, you know what? With a voice like yours, you would think that you were an airhead, but when you listen to you, you kind of know what you're talking about. So I was so offended, but you can't say anything because they're grading you. So I took it. And then later in the rotation, which was about 4 weeks or 6 weeks, I had to meet with him for him to give me feedback. And his feedback, he asked me, so what are your plans for after medical school? And at that time I was enamored with medical education, which is funny because now I work in telehealth and not really with students, but I have the side podcast and mentorship still going. So I was passionate about student education at the time. So I told him I would probably go into academic medicine and primary care because I enjoy primary care. So he took a step back and he looked at me and he said, well, do you have a plan B? Because number one, you're a woman, and number two, you're a minority, so it's probably not going to work for you. And that was my experience. So I discussed that in the chapter of the book, Medicine Women, and I talked about how it kind of impacted me and caused some imposter syndrome, but there is something that came out on the other side where now I'm able to talk to young women who may be going through the same thing and tell them that it's okay. You don't have to listen to the words they told you, and you can't let anyone dim your light.
Right. That's a good response. That's great. We have to bring you back and have you talk about that topic. Don't let anyone dim your lights. But you mentioned the imposter syndrome, and a lot of people, many of us have heard the word before, but may not understand what it means. So could you share with us, what is it, what it means? Elaborate a little bit for us.
Sure. So to me, imposter syndrome means thinking that you're not good enough because of things that aren't necessarily true, things that you're kind of making up in your head in comparison to other people. So it may prohibit you from doing things because you're thinking, oh, I can't do that. She's already doing that and she's doing it well, so why not me? Or thinking or going in, even when you're in medical school and you want to apply to something that's very competitive. So in medicine, certain specialties, you have to have certain grades or certain letters, all of these kind of things. It's like the ultimate draft. So say if I wanted to be like a neurosurgeon, and I had imposter syndrome, I'd be like, yes, my grades are the same as this person who's also applying. And yes, I'm in all of the leader of all of these student groups. And yes, but they're never going to pick me. So I'm not even going to apply. So kind of knocking yourself out before you even get there. But it comes a time when you just have to take a step back and say, okay, they may say no, but I know that I'm excellent. So what's going to happen if I don't try? I won't get it. But if I do try, I could possibly get it. So why not try and let them tell me no? Yeah. So that's my motto now.
I got it. Yeah. So it's like a feeling that they may not pick me because of. Could be, I'm not good at whatever.
Labeling yourself.
Is it fair to say that people, regardless of the demographics, deal with that imposter syndrome? Yeah. Okay.
Absolutely. I was doing a LinkedIn education with another organization that I worked at called Girl Develop It, which increases the amount of women and non-binary people in technology. And we were trying to show them like tips for LinkedIn. So one of the things that I told them is, especially with women, we always feel like there are studies that show that women usually do not apply to jobs unless they meet every benchmark that's listed on the job description. Whereas men, they're usually like, oh, let them tell me no, let me just apply to everything. And a lot of the women were shaking their heads because they're trying to be the best and they're trying to hit that benchmark. And And it's okay not to do it. It's okay to just say, all right, let me shoot my shot. Let me show them who I am, and I'll either get it or I won't. But it's something that I think a lot of people deal with.
Mhm, for sure. Yeah. Now, I know that you are a professional speaker. First of all, what attracted you to the craft of speaking?
That's an interesting question. I will say that number one, I've always been chatty like my whole life. When I was little, my family members, they nicknamed me the like little news reporter. So I've always liked to, be in the tea. But I think over time, as I've been on panels and things, I always have been in student leadership and stuff like that, and continued through that. I kind of grew. And then I started to speak for certain things that I was invited to. And during the pandemic, I think everybody had some time of reflection. So I started to speak for different events that were happening, and I figured out that I kind of liked it. So that has just grown over time, and I've actually started my like healthcare media organization where I do speaking engagements. I consult for different healthcare organizations and do some writing. So it's definitely grown from there.
Okay. Now, I want to touch upon maybe three of your favorite topics. I'm going to pick one.
Okay.
Yeah, but I want you to pick two, and unless if the one that I want you to mention doesn't come up, I'll say, well, what do you do with this one? So your top two topics as a speaker that you love sharing with audiences. And then what do you do with them? What do you try to do with those topics? Yeah.
I think number one, I love sharing with audiences is about, we talked mostly about healthcare disparities. I'm very passionate about decreasing those. Another topic that I love talking about is overcoming obstacles.
Mm.
Because as we've seen, like everyone has their barrier, their obstacle, and everyone's journey isn't the same. But it's definitely a great thing to kind of share that so you can start conversation so people can get rid of that imposter syndrome that they have, because there's no place for anyone.
Yeah. Well, that's why I started the Possibility Action Network. That's right. It's possible. But look, here's one topic that I saw associated with you as a speaker. It caught me because I would not have thought about it before meeting you.
Okay.
And yeah, and it's something I might have changed it a little bit, but it's not too far from what I saw. It was something like, and I'm paraphrasing, Doctor Talks Cultural Awareness. I've never, in my almost 70 years of living, ever hear anyone associated a medical doctor talking cultural awareness. So why that? What if I got that right? Am I right?
Yeah.
Okay, so why that topic? I mean, you're my first doctor who talks cultural awareness.
I think that it definitely needs to start in the healthcare system because all cultures come to the doctor. So if we're going to fight and kind of fight our biases and work to decrease health disparities and work on increasing diversity, it should start with being aware of different cultures. My culture may not be the same as your culture, may not be the same as other ones. So even within our Blackness, being Black is not a monolith. So figuring out that and then figuring out other cultures as well. So I love talking about that and figuring out how to become culturally competent. So when I was in medical school, I mentioned that the dean of the school, she was talking about the medical school entrance exam, the MCAT, and her meeting with the students of African descent. She mentioned that there was an article that came out that said that the scores were lower due to the Black people.
Ooh.
And number one, that was wrong because we were in that early program that didn't require the MCAT. Number two, she was like, yeah, and not the Africans, like African American. We're like, African. It was just offensive. All foot in her mouth. So from there, we did not just take that standing. We actually advocated to have cultural competence. And we created a curriculum that was implemented and now is taught to all of the first year students, even up until now. As of when I've gone back, they're still continuing it about 15 years later.
Wow.
So that was my initiation into culturally competent work. And from there, it's grown like through residency. And now when I'm doing consulting for different organizations, like figuring out different things, like when you're talking about wellness, like I did a talk with one of the organizations who gives wellness benefits. And they hired me during Black History Month, which for those who are listening out there, you can speak to Black doctors outside of Black History Month, and you don't have to book them only in January, toward 2 weeks before. Pet peeve of mine for those who are listening, we can talk about lots of topics, but my topic for them was that. And we talked about how you need to think about benefits in terms of cultural awareness, why someone in your office may be sad and not want to talk because, I don't know, maybe someone was murdered. Once again, like there are all these Black people who get murdered, but they want to know why, or they want you to be the spokesperson as to how Black people are feeling, which I've personally experienced in some organizations. But you can't have a benefit that benefits everyone. You may need wellness days and you may not have to ask why, or people may take off for Kwanzaa. And my friend may take off for Kwanzaa, but I may not celebrate it. So just don't assume that I'm going to take off that week too. So there are so many different realms and reasons for cultural competence, not only in the African American community, that's just kind of what I'm highlighting now, but in all communities, and just trying to figure out different things to help different people feel more a part of the system and feel more aware. Or even when you are in a healthcare setting, going in a room and not being upset when a woman of Muslim descent does not prefer a male OBGYN or something like that, like respecting people's wishes and trying to know, like, meet them where they are so they'll feel comfortable with you.
Yeah, I get it. Yeah. In addition to everything that we've talked about, I was curious about just a couple of other things. And one is, if you're a busy doctor, you're a public figure on the rise, and then I noticed that you take the time to mentor medical students. And I asked myself, why does she care? At this point. So tell me about that. Why go back? Why are you giving back like that?
I love giving back to medical students because I feel as though they're the future. Without them, there is no healthcare. We talk a lot about why there are a lot of physicians leaving medicine and why we only have 5%. During the pandemic, I think about 15, or it rose to 20 or 15% for matriculation of African American students. So it kind of drove people to go. So you need people to be there to inspire you. I definitely depended on my predecessors to kind of help me get through when I was in that situation at my school. And sadly, when you think about it, I was in a well-supported Black-rich school because there were 15 of us in our class of like 200. So that was unheard of. When I would go to conferences where I was very involved, and I still am involved with the Student National Medical Association that supports minority students in medical school, because historically you may have heard of the American Medical Association, but back in the day, they did not allow Black people to be a part of it. So we created our own, and still running strong. But when I would go to those conferences, I would have a person who would be in awe, and they'd be like, oh, it's only one of us or only two. So building that community was definitely strong within the SNMA. So I definitely love giving back and showing people, like, it's okay, it's better on the other side, or here are some tips, or here are some pitfalls that I fell into that I want you to avoid. Because if you just do what you want to do for yourself, you're not helping the community at large.
I got it. I know from experience that serving as the host of a podcast show takes a lot of time. Why did you do it? Why are you doing this?
I'll be honest. I'll start with the beginning.
Okay.
So like I said, I've always loved mentoring students, and what better way to reach more than through a podcast? Because instead of being that one-to-one or that small group, you can reach hundreds, if not thousands of students at once. So I love that. I love being able to show with pre-meds and med students different career fields, hot topics in medicine, have open discussions. It's great. But it was a surprise to me too that I inherited a podcast. I have a podcast called The Perspective Doctor, and it had been around for about a year before I actually took it over from a prior host. I saw a Facebook message during the pandemic when I was looking to connect with other people because I'm chatty, I'm a people person. I love interacting with others, and I was looking for different ways to meet people. And what better way than to see someone on your screen when you couldn't go outside like that than having a podcast. So I answered the call for the pre-med podcast, and I interviewed and I told them about my passions of helping other students and things like that. And now I'm about a year and a half, almost 2 years in.
Congratulations. That's awesome. That's awesome indeed. Yeah. Last question for you. I know that Boston University School of Medicine gave you the Tom Pollard Award. I think it was a humanitarian award. What is that, and how did you feel when you received this award?
That's awesome. That was a while ago because I'm getting up there. But it was a Tom Pollard Award for Humanism in Medicine, given by the Family Medicine Department, I think. And I've told you how I always loved primary care. I thought I would do it, but I went into my medical school clinical rotations with an open mind because I didn't want to get to family medicine and be like, oh my God, I hate it. Why didn't I pay attention to anything else? So I went through it, but I had always been involved in the primary care and the family medicine interest groups. We had leaders and stuff, and I was one of those. And I developed relationships with my mentors in medical school. So BU wasn't all bad. For those listeners out there were some excellent people and there's some wonderful mentors. Shout out to Dr. Nanette Harvey and Dr. Joanne Wilkinson. They were amazing. So I had some mentors in medicine. And one thing Dr. Harvey told me when I was thinking about what I want to do, she was like, just go with it where you find your people. So when I did my family medicine rotation, even though I had to drive an hour away because they had us in different clinics, I looked forward to going to it every day. I was talking to my mom on the phone and she was like, you're really excited about this. And I was like, I kind of am. So I knew they were my people. And I was growing in the leadership there. And then I mentioned the Student National Medical Association. So they had a national medical board and things like that. So I ended up becoming a community service rep for our school. And then the next year I was a regional service rep. And then I became the national community service rep, where we had the 50th anniversary March on Selma and all of these kinds of things. It was amazing, doing a lot of community service for the nation with this organization. So of course we did a lot of events in the Boston area. So I think with that, they kind of thought that I was a good human or whatever. So I was awarded the Humanism in Medicine Award.
That's wonderful. That's wonderful. Well, Dr. DeRoyan, is there anything else that you want to share with us that I have not asked you about?
I think that we covered a lot of things. I think that I'm very thankful for the Possibility Action Network. I think that you guys are doing great things. I love chatting about my experience in healthcare. I know that it'll grow. I want to mention to all of those listeners out there, it's not live yet, but I'll probably be messaging you guys. I recently did a TED Talk on communication in healthcare, talking about telehealth. So I would love for the listeners out there to watch it when I post it on LinkedIn and just tell me how you would like to contribute to healthcare, because one of the things I bring up in it, and it'll make more sense once it comes out, is about becoming a pacemaker. Wow. So that means that you don't necessarily have to have a healthcare background to change the system. So I'm working on creating a network for pacemakers, and people who follow me on LinkedIn or Instagram will hear more about that. but I would love to kind of just highlight that because I think that there's so much hope for healthcare. And we've just seen that in these past few years, the types of technological advancements that we've made will hopefully make people healthier and help us engage more with one another.
Mm.
So I appreciate you inviting me to come on the podcast. And I'll just say goodbye to the audience. Thank you guys.
Okay. Well, I'll tell you what, it has been truly my honor to meet you and to talk with you on this show. So thank you, Dr. Duroin. You've been listening to the Possibility Action Network podcast. Our guest today has been Dr. Urquidda Duroin. I'm your host, Stephen Middleton. Until next time, good day